Chairpersons of the next session, Dr. Mrinal Kanti Das, Dr. Dhiman Kahali, sir, please you stay back here on this side, and Dr. Alok Majumdar on the stage. We will have two esteemed guests from Dhaka here, Dr. Dhiman Bonik and Dr. Ashok Datto, who will show live in box cases. The time is 12 minutes plus 3 minutes of discussion if you want discussion, sir.
So this is a very important session since the international faculty from Bangladesh will be presenting two cases one after another. Over to Dr. Dhiman Bonik, please.
Respected chairpersons, moderators, and case senior doctors and colleagues. This is the hospital from which you are seeing the live case. I am from that hospital. My case is where the distal left main is the main issue of doing the PCI. This is a gentleman of 55 years old who had presented to me with a chest pain of class 3 angina. He had a non-ST segment elevated MI 1 week back. He is hypertensive and had a strong family history of ischemic heart disease. His ECG shows T inversion and in V1 to V6. His echo reveals no regional wall motion abnormalities with ejection fraction normal, 60%. So we underwent an angiogram for this patient. Angiogram reveals there is a slight tapering of the distal left main, around 30 to 40%. And LAD has a slight tapering at its ostial part, origin, and had a mid-segment 70% lesion in LAD. LCX has a tight lesion of 99% at its ostia. RCA is free of significant disease. So, as this is the life in box case, I want to have some opinions for this case. I have done the syntax score of this patient. His syntax score is 24. So, I want to some opinion for this patient, and next I will see what I did for this patient.
Yes, Alok, what's your comment about the angiography part?
In the LAD, the mid-segment lesion doesn't appear, at least on angiogram, to be very severe. I think an FFR should be done for that lesion. As regards the circulation, it's obvious it's around 90%. That would be my strategy.
So this will treat as a bifurcation lesion, and there is a significant disease in the left circumflex ostium. But the left main lesion is not that severe, because we know that in the distal left main normal anatomy is that there is 20% narrowing of the distal left main. That's normal anatomy. But we have to do some IVAS or FFR to fix the things further.
I think we completely agree on that. We must see the left main distal part along with the other branches with the help of IVAS.
Actually, I had done the IVAS pre-PCI. I have done the IVAS post-PCI. In doing this case, as the patient has a chest pain, as he had syntax score around 24, so I had an attempt to do a PCI. Doing a PCI for this patient, I have the following points came into my mind: stenting of the ostial LCX and the mid LAD separately. PCI, another strategy can be done, that PCI to the left main to LCX, single stent strategy, with the mid LAD separately. This is a second option. This may be an option. And another option may be PCI to the left main to LCX and doing the LAD as a double stent strategy. In doing this patient, you can agree with me, the distal left main is slightly involved. There is no landing zone is present for doing the ostial LCX without covering the distal left main. It is the main issue of this doing PCI for this patient, because the LCX is ostial disease around 99%, and there is no landing zone for the proximal part of the ostial LCX to be present. A minor plug is present in the ostial LAD, and the mid-segment LED is significant. And the angle between the left main to LCX is more than 90%. So recross of LCX will be difficult. With these things in mind, I went for PCI of doing this patient. I take an extra backup catheter of 7 francs. During PCI, this was the view. I wired the LED first with the run-through floppy wire. Wiring of the LCS was very difficult, and I finally managed with the help of a microcatheter.
What wire you have taken for LCX?
Run-through floppy wire. The angle was very difficult to cross, and finally I managed. So I pre-dilated the ostial LCX from the left main with 2 into 15 non-NC balloon with an NC balloon. After pre-dilatation, this shows like this. Then I put a 3.5 into 30 millimeter dark eluting stent from the ostial left main to the proximal LCX. In the live case we have seen, this is the view for doing the ostial, covering the ostial left main, iliocranial view, and I dilated up to 12 atmosphere. Immediately after the standing of the left main to LCX, LED, ostial of the LED seems tapering. So I recross the LED through the stent stud. Then jailed wire is taken out from the LED and the stent stud is open. And 2.5 into with the 2.5 into 15 millimeter with an NC balloon. After opening of the stent stud, this looks like this. Then I put a 3.5 into 38 millimeter drug eluting stent covering the mid left main to the lesion in the mid LED. Stent deployed up to 14 atmosphere. After standing of the left main to LED, this looks like this.
You didn't post dilate because there was a undilated portion in the distal portion of the stent.
Yes, I did it. Then I rewired the LCX through the stent stud, double layer stent stud. Then jailed wire in the LCX is removed and is post dilated with 3.5 12 NC balloon. I post dilate the LED with the 3.5 into 12 NC balloon. I post dilated the left main with the 4 into 8 NC balloon. I did a pot in the left main with a 4 millimeter NC balloon. Final kissing with the 3.5 15 millimeter in the LCX and 3.5 12 millimeter in the LED NC balloon at 14 atmosphere. Then I did an IBUS. From left main to LED, the LED stud is well apposed.
Could you show us the ostium of the
Yes,
left main?
yes,
Ostium
yeah.
of the left main.
Yes, this was the bifurcation. Then this is the left main double stent, well apposed double stent. Then I did an IBUS, again an IBUS from left main to LCX. LCX stent is open and this is the bifurcation. This is the left main. So, this was the final view.
With what balloon you did the pot in the left main? What size balloon?
4 into 8,
4 into 8. At what atmospheric pressure?
up to 14 atmosphere. Not moving. And this was another view. So, learned audience, you all will agree I have done a culotte for this patient. Intervention of doing an ostial left main and ostial LCX is always challenging. It is more brainstorming if distal left main is involved. Then comes the question how to maintain the carina. In culotte technique, we use two stents that leads to the full coverage of the bifurcation at the expense of the excess metal mass in the distal left main. Rewiring of both the branches through the stent starts is difficult and time consuming. Culotte technique probably gives the best coverage of the carina. Final kissing is mandatory when treated bifurcation lesion with double stent strategy. IVAS is a very good tool in doing such a case. This is our cath lab team.
Okay, very well done, Dr.
Thank
Bonik.
you all for patience hearing.
But one of the problems, very well done. Give a big hand to Dr. Bonik for this wonderful presentation. Thank you very, very much for this excellent case. Now, there is one question that, in culotte, there are two layers of metals proximal to the bifurcation, and there is a definite shift of the carina also. And it's very difficult to recross the, side branch through the two layers of. So, what do you think? Because, in tap or other things where the angle is more, it's very difficult to do because there is no recrossing of the side branch.
Yes, it was more challenging for me. In our cath lab, we use Oxfordian wires, commonly, old wire.
It becomes still stiffer, tougher, with Oxford
But
wires,
in
yeah.
this case, I use an N wire. Our technicians and other persons are very friendly to me, in giving good wire to me. The sir will give, sir is more familiar to our hospital.
No, actually, culottes is very labor intense as well as hardware intense kind
Yeah.
of technique. So you have to be ready to spend long time if you
Yeah.
are doing culottes. But it's a very good technique.
Yeah,
It's the
good
best
technique.
way to cover the left main bifurcation.
Yeah.
Metal coverage is probably the best with culotte compared to any other. In fact, whenever you do bifurcation two-stent strategy, the maximum restenosis is at the circumflex mouth. And my feeling is culottes would avoid that. The only issue is when you are putting the left main to LED stent, you had not pulled out the wire of circumflex. That was an intention or inadvertently. Because here, you already deployed a circumflex stent, you're deploying a left main stent, and the wire is actually getting sandwiched between two layers of metals. So that could be one thing which you can change next time.
Yeah, I agree, Shirish, what you told that EBC, European Bifurcation Society, they also advocate for more of culotte, and they tell that it's more better than tap or better than, DK crush. But DK crush 4 has categorically shown that it's a better technique, and, DK crush avoids all this. And it also covers the side branch ostium very well with a very low restenosis rate. And actually in the DK crush, the restenosis rate and MACE was as low as 5% in the left main bifurcation. And now EBC is taking onyx stent, they're putting onyx to the left main, and they're taking 450 cases. It's an ongoing project with the leadership of Schiaffo from Italy. And they are seeing what happens, what is the best stent strategy, single stent strategy or double stent strategy in this EBC trial with 450 patients with left main stenting, and they are putting onyx in all the patients.
Dr. Hiremath, would you have done differently in this particular case? Say, for example, the meat portion of the LM was also stented in this particular case.
Yeah, I think it was done beautifully.
Yeah.
I would probably follow all the steps. I think it was circumflex here was critically diseased.
Yeah.
We have to address circumflex first, and this strategy allows us to cover the area perfectly well. So I think it was very well done.
So,
Ramesh, have you any comments, short comments to make, because you are a pioneer in this field?
I I agree. Never jail the wire for culotte or for any sort of DK crush, any technique, double vessel stenting. Never jail the wire between two stents. I mean, I have forgotten and I left it as well at times. If it's a mistake, it's a mistake. You cannot, repeat it. But unfortunately, but fortunately, you cannot plan to leave the wire. Don't leave the wire. The jail wire sometimes can break. I always use non-hydrophilic wires in the side branch. Thank you.
That's important.
I think that's very nice from Dr. Bonik. Let us give a big hand and we'll go to the next place.
Thank you.
Next place.
Yeah, next case is presented by Dr. Ashok Datto. So I would invite Dr. Ashok Datto to come to the dais and present his case. Are you ready, Dr. Datto? Yeah. Come to this side.
So, good morning, my respected chairpersons and learned audience. I am from the same institute from Dhaka. This is a post-CABG triple basal disease. 60 years old, gentleman, smoker, dyslipidemic and hypertensive, non-diabetic, CABG done in 2014 with triple basal disease, about 1 year, that was 1 year back. Chest pain on report, class 3. For last few weeks, ECG shows T-wave inversion in the enterolates.
Nothing coming.
Echo reveals some wall motion abnormality with EF around 45. ETT was done and it was positive. So this is the resting ECG showing STTF change in the enterolates. ETT was done, I don't know why, because so classical symptom with this type of ECG change definitely that needs angiogram directly. So ETT shows ST depression in all leads with elevation in the AVR. So this is the check angiogram. Left ventricle severely reduced. LED has got disease, LCX other than ostium is free of significant disease. But OM on, that is totally occluded from its ostium. This is the right coronary artery, large vessel, proximal to mid, critically stenosed. This is the graft to the PDA, that is totally occluded. And this is the graft to the OM mildly disease at distal anastomotic site. So this is the lemma. So this is what should be the option, redo CABG, PCI, that party was agreed, but that was again high risk, severely calcified, so many rotablation, wiring to the LED may be challenging, cost is an definitively issue. Ultimately, the party agreed and we decided for PCI after 2 days. So this is the first view after 2 days. We start with right coronary artery, wiring done, pre-dilatation with 2.5 15 millimeter NC. Then 3.5 38 millimeter DES at 14 ATM. And post-dilatation 3.5 15 NC balloon, giving a good result. And you see there is some collateral from the right to the LED. Now, wiring of the left main to LED run through floppy wire with the help of microcatheter fine cross. That was challenging, but anyhow that was successfully done. There's a lot of calcium in the left main as well as proximal LED. we planned for rotablation, exchange with rotawire. So 1.25 millimeter bar, several runs. Then bar is upgraded with 1.5 millimeter. So this is the result after rotablation. So now LCX wiring done. So now IVASM is, you see a lot of calcium in the left feature, more than on 80 degree. On the right, the LCX ostium was good. So plan to put a stent from left main to LED. So now balloon dilatation with 212 millimeters. It was difficult to inflate the balloon totally. It was not uniformly dilated. So at one stage balloon burst. You see on the right side. So we took a 2.58 millimeter NC balloon, pre-dilated once again with better result. Now stenting from left main to LED 4 into 34 drag LED. In cranial view, ostium of the left main is stented. Inflated at 14 atmosphere. So this is the result. LCX is recrossed. So now post dilatation with 4 into 10 millimeter NC balloon. Left main and proximal LED. Now again IVAS to see the stent expansion and distal to the stent there was a lesion in the LED. Now second stent 3.5 26 millimeter DES overlapping the distal end of proximal stent. So this is the final post dilatation with 4.5 millimeter in the left main NC balloon. So this is the final result. That was done in 2015. Till now the patient is doing well and regularly followed up. So in conclusion, during post-CVG revascularization, first you have to select which vessel, whether native or graft vessel do you want to deal with, and consider the procedure, related complication and its outcome. Rotablation and left main stenting ejection fraction is a major determinant for short and long-term outcome. Rota is safe if left main is protected from the right side. IVUS is a good tool for left main stenting for vessel calibration, stent apposition, calcium detection. So thank you all.
Okay, Dr. Datto, very well done, very nice presentation. Any comments from the panelists?
I think the case went very well. So far the stenting is concerned in both the arteries. And you have left the circumflex for any particular reason, or it was a pre-planned one?
Yeah.
The-
LCX?
Yes.
No, LCX I did not do anything because ostium of the LCX was good and there is a good flow. So,
Okay, fine.
So you see.
Any comment from the audience?
The point is that you routinely keep temporary for rota in your center?
No, actually for right coronarily we routinely do put the temporary. But on the left side, if not complicated patient is with good hemodynamics, usually we don't put rota routinely for the left side.
We don't use mostly. And one thing is, I just asked Dr. Hiramata about it, that after we put a stent from left main to LED, the first procedure what we should do is a pot of the left main, because once you are gone between the stent stud and the wall, you'll never be able to know. What is your opinion? I mean, we forget about the gelling of the circumflex wire or anything, but pot is should be the first step of the left main, initial pot.
Yeah, I think pot is an absolute must. Once you put the stent, come in with her shortest length balloon, 6 or 8 millimeters that we have. Do a pot. A pot will clearly show that the proximal stent is big, distal stent is small. And in that hinge portion, you can push your side branch wire. So I think pot at that stage would be a very appropriate step.
So one suggestion, that is the stent balloon is compliant or mostly compliant or semi-compliant. If we pull the stent balloon back into the outer and go at high 18 or 20 millimeter, does it make a bit some degree of pot?
We can call it poor man's spot, because you're trying to say on balloon, but I don't think it will give you the same feeling that you would get with a non-compliant balloon. Maybe to some extent, yes, but not the same.
Yes, thank you, sir.
I think what Shirish has emphasized in the last case also.
So one thing that is at the Dr. Datto, there's some left main stem LED, there's some mismatch, there's some area, there's some constriction there, the confluence area, no? You could have given another spots that we push dilatation, and that area is essential.
Thank you.
Ramesh, any comments from you?
So the rotoblator, I think, due to cost, we don't go higher on the rotoblator device. I would recommend 2.0 for left main for rotoblation. And pot with semi-compliant, what happens is if you want to compliant balloon, if there is a restricted area, when you go up with the balloon high pressure, still it doesn't yield. What happens is it just edges will become bigger. So the middle.
So relation remain like this.
So and I think
that's a good issue.
Right, and you are going to increase the size much more in other areas.
Than
you need it.
I think let us give a big hand to all the speakers who have done extremely well. And one must remember that in a left main stenting, we must not forget about the pots, which is very, very important to avoid many other complications.